Thank you very much for joining us for the webinar this afternoon, and I appreciate your time, especially on this day, which is Mandela Day. Hopefully, people are doing something related to that, but nonetheless, thank you for sharing your time with me this afternoon. So I'd like to, so really the aim of this talk is to tell you a little bit about what we did in terms of universal school-based mental health research and how we went about doing that and what we found. And then to talk about some of the challenges and opportunities and some considerations methodologically. And, you know, in that part of the talk, we can also really open up for discussion if people would like to share some of their insights. And perhaps you've done some work in schools yourself. And you can contribute to the conversation in that way. So I'd really, at the end of the presentation, when we sort of open up for questions, would like to allow a discussion for those who may be interested in that way. So in order for me to talk about what we did, I think it is important to also just contextualize the problem a little bit, and that really is then talking about what we know about child and adolescent mental health globally and then within South Africa. So globally, we know that 10 to 20% of young people experience a mental health condition, half of whom will experience this condition by the age of 14. In quite a comprehensive global system or meta-analysis on the prevalence of mental health conditions in children and adolescents, Polenziak, I'm not going to try and pronounce that correctly, and colleagues found that 13.4% of 10 to 19-year-olds live with a diagnosed mental health condition, 2.6% of whom have any depressive disorder. So just noting there, any depressive disorder, so not major depressive in particular, and 6.5% any anxiety disorder. So that's still quite substantial. More recently, in a systematic review by Jorns Presentati, the colleagues found that about 27% of young people in sub-Saharan South Africa specifically are living with depression at any given time point, and 30% with anxiety. So globally, this gives us an indication of just the enormity of the problem that we face among children and young people in terms of common mental disorders in particular. So in South Africa, while we may have no national prevalence data, there are some studies from the Western Cape in particular that give us some indication of the prevalence of common mental disorders amongst young people. In 2016, with just over 1,000 young people between the ages of 14 and 15, using the short mood and feelings questionnaire, about 41% of young people reported symptoms of depression. And using the Zung anxiety scale, 16% symptoms of anxiety. More recently, in the Western Cape, amongst just over 600 young people, 10 to 14 years, 33%. So you can see I've highlighted these in yellow and pink just to show the sort of similarity across these two cross-sectional studies. That just close to 34% reported symptoms of depression using the PHQ-A, so the Patient Health Questionnaire, the adolescent version, and about 21% symptoms of anxiety using the GAD-7. So the PHQ and the GAD-7 are the most commonly used measures for reporting symptoms of anxiety and depression amongst children and young people. That, as well as the revised Child Anxiety and Depression Scale, which is the measure that we used in our study in particular. So taken together, these data show us that young people are at considerable risk of developing mental health conditions. And we know that if left untreated, these conditions will persist and worsen in adulthood, ultimately leading to requiring diagnosis and treatment. And also that poor mental health in childhood is then linked to poor school performance, criminal activity, and of course, increased risk-taking behavior. So we know this. And despite knowing that there is a large problem here of many children and young people living with these issues, living with these mental health conditions, we know that there is also a sizable treatment gap, at least 90% treatment gap in South Africa in particular, where 90% of children with the mental health conditions are unable to access care. And this presents numerous issues, and there are also various barriers to seeking help, which I'll talk about in a minute. So children and young people in South Africa are particularly vulnerable because of what is known as the social determinants of mental health. So that means that in addition to the biological and the psychological and genetic factors that may make an individual vulnerable to developing a mental health condition, there is also numerous social determinants. And a lot of this work has been done by Professor Craig Lunt and colleagues. Indeed, they had done the systematic review that was published in the Lancet that identified these 5 key domains of social determinants of mental health. And these key domains are the demographic, the economic, the neighborhood, the environmental, as well as the social and cultural factors that may contribute to vulnerability to develop a mental health condition. And then they also speak about these proximal and distal factors. So they give the example that, for example, within the economic domain, that the distal impacts of the economic recessions that were precipitated by the COVID-19 pandemic had an impact on depression outcomes in working age adults through its effects on proximal experiences of financial insecurity, food insecurity, unemployment, and eroded assets. So that's the example that they give of how these social determinants then impact on mental health. So these are the conditions that make young people and all people in South Africa really particularly vulnerable to this risk. And in addition to that, we have numerous barriers to seeking help. So fundamentally, for children and young people, they ultimately rely on their caregivers to be able to identify and then refer them for help. And so caregivers are both their parents, but also teachers, to be able to identify when young people have problems and then to be able to link them to care. But there are numerous barriers, including a distrust in the healthcare system, stigma, which is pervasive, financial costs associated with seeking professional help and care, time, specialist treatment. We know that since 2019, there's only about 15 child and adolescents, 1 geriatric and 7 forensic subspecialist psychiatrists practicing in the country. So specialist treatment is quite scarce. And then an important barrier that I've left out here is then, of course, that of mental health literacy as well, which is then important for initial symptom identification amongst caregivers, so parents and teachers. So there is huge vulnerability, various barriers to seeking help. So this then, positions us for wanting to do work that is in the realm of prevention. So what can we do to mitigate the onset of these common mental disorders? What can we offer at large scale that could help to address these problems early on? So focusing on prevention is then an important public health objective, and being able to focus our efforts early on. So being able to build resilience as early as possible. So that working in primary schools in particular has been a focus of ours, and then being able to reach children where they spend a considerable amount of their time, which is why schools have been such ideal settings. We know that in South Africa, more than 90% of children do attend school. So this is a viable platform for these sorts of interventions. So in 2022, 2021, 2022, the South African Child Gauge focused on child and adolescent mental health in particular. And you can see that these domains that are listed here in this table are the domains that were identified as the social determinants of mental health. And in the demographic domain, they in particular school-based mental health promotion interventions are advocated for to improve social and emotional competence and resilience in children. And they show there that most of the evidence that we have comes from, so here they refer to it as high-income countries. Increasingly, we refer to minority and majority world countries. So a lot of the evidence that we have come from minority world. And they also have limited evidence of long-term impact. So we know much less about it in the South African context, which is also good motivation for this work. So schools are ideal settings, and this has been identified globally, that schools are ideal settings to focus on prevention and early intervention. And lots of work has been done elsewhere. In fact, there is so much work on school-based mental health settings elsewhere that, and this is what I'll talk about a little bit later on, is that now we've also come to learn about the potential harms associated with universal interventions. So aware of that. And we'll talk a little bit about that later on. So schools have an obligation then to recognize the special health and development needs and rights of children and young people. So schools have an obligation then to, if there is a mental health emergency, that it also is then a vehicle through which prevention efforts can be focused on. It's accessible to most children. Schools are accessible to most children. They focus on skills for life. So there are programs within the school curriculum that focus on skills building. So focusing on building resilience is then would fit well within an existing curriculum. And also being able to discuss mental health topics openly. So through this universal implementation allows for to mitigate the potential stigma around only focusing on those who may be at particular risk. So then what do we mean by universal? So it's just that. It's being able to provide an intervention to all learners within a particular school, so that the intervention is not only delivered to those who may be considered at risk. So for example, if we were to administer or have children complete measures, so the QA or the GAD-7 or the revised children's anxiety and depression scale that I mentioned, and we might have those who score within the clinically significant or above certain cutoff scores, that we don't just focus the interventions on them, because that might require us to remove them from their classes and offer them an intervention support in a different space within the school, which may then inadvertently identify them as having a mental health problem. So that's the idea around that. But we're not saying that universal interventions is the only thing that needs to be offered. Of course, we know that there is that interventions need to be offered at various levels. So in the context of providing support that is non-stigmatizing to all children who may otherwise not have been able to access care, universal interventions are important. But those learners who do need more targeted support, that support should certainly still be offered to the extent possible. So in the schools that we work within, we work closely with an NGO, Community Keepers, who's been fundamental to the work that we have been able to do. And so it was important for us ethically to be able to pair with Community Keepers, so that in the case that any of the young people that we work with required additional support, that we had that referral mechanism in place. So over and above the key role that they played in informing the intervention itself, they were also an important referral mechanism for us, acknowledging that there may be young people who required some more support. So our aim was then to develop a universal school-based intervention, and we did so then through two key phases. One phase which had to be revisited due to COVID. So that gives you an indication of the timeline of this work, which essentially began in 2019. So we had to start with a systematic review. We had to ask, what is known about universal school-based mental health interventions in low and middle income countries? So what exists, and, did we need to develop something new, or could we adapt something that was existing? In the instance that we needed to develop something new, which is what we did, we had to find out what the intervention should look like and who should be involved. So that was also part of phase one. And this also then involved expert input, and expert input is conceptualized in the broader sense of the term. So that is the experts themselves, the learners for whom the intervention was intended, as well as their parents, teachers, and school counselors, but then also those with expertise in the underlying theory which informed the intervention, which is cognitive behavioral therapy, which I'm not going to go into too much detail about, but also then making sure that we were paired with experts in CBT to be able to inform the manual development and the training. and the supervision as well. Sorry. Phase one had to be revisited. So I'll talk about what we then did when we were actually aiming to be able to deliver the intervention then. And then phase two, I'm sorry for that, entailed piloting of the program. So we then conducted the systematic review, which we had registered on Prospero with the aim to understand what interventions had been delivered specifically to reduce anxiety and depression. So at the time when we had first conceptualized this work, we were very much interested in reducing symptoms of anxiety and depression at the end. But in our work, and which is consistent with other universal interventions elsewhere, we know that the pre-post scores were non-significant. So we didn't find, and I'll talk about this more a little bit later on, or small to moderate effect sizes when these are the primary outcomes. And so we need to think a little bit more broadly in terms of perhaps well-being indicators, and focusing less on reducing anxiety and depression, but more on promoting well-being. And looking at outcomes such as self-esteem, or emotion regulation, self-regulation, so variables related to well-being rather than to specific mental health outcomes when we're talking about universal interventions and resilience and skills building. So at that time, we were interested in school-based interventions in LMIC among school-age children. We looked at all study designs, and we were quite interested in measures of depression and anxiety. So we had hoped to do a meta-analysis, but given the heterogeneity in the measures that we used, we were unable to actually do that in the end. So we just published the systematic review, and we covered about 19 years worth of studies. So I haven't presented here the whole prisma diagram of how we came to the 11 studies, but it's certainly documented in the paper. But we found that the studies were included in countries such as India, Colombia, Indonesia, Mauritius, Mexico, Chile, China, Nigeria, Uganda, and Turkey, most of which delivered randomized control trials to one group who received the intervention and the other group who was a control group who was often placed on a wait list. So they would then receive the intervention at a later stage, which is a similar model to what we followed. That most of the interventions were psychoeducational or health promotional in nature, 3 of which had cognitive behavioral therapy as an underlying theory. That the sessions that were delivered were on average 10 sessions of an hour long, which is quite long, 1 to twice per week. Thanks. With the average population group of grade 5 to 9 learners. So falling within the age group we were interested in. So we found that in the studies that we looked at, the interventions were mostly delivered by teachers, with researchers and counselors in some cases. And it's important to highlight this because in the formative work that we did, we actually found that our learners and teachers themselves told us that they did not want to be responsible for delivering the intervention. Learners didn't feel as though they would feel comfortable with opening up in front of their teachers, and teachers didn't feel like it was within the scope of what they needed to do to provide mental health support to their learners. So this was different then from the findings from this systematic review. Parents were mostly not involved in the studies that we looked at, but received informational sessions in 2 of the studies. And this was then important in our work too. Parents expressed that they wanted to be involved, but couldn't because of various commitments to work schedules that they were unable to take part in. Many also felt as though they might hinder the support their children received if they were involved in some way. Or felt as though they might be judged by the teachers. So parents were mostly not involved, but parents in the work that we did nonetheless expressed a desire to want to be involved, not only to support themselves, but also to support not only to support their children, but to support themselves as well, and to improve their own mental health knowledge. So actually finding ways to include parents in interventions like this is becoming increasingly important, and is currently being undertaken by one of our doctoral students. So most studies found significant improvements in anxiety and depression, but those effects, as I said, were small to moderate. That the interventionists or the delivery agents receive training and support and supervision to be able to deliver the interventions, and there was a wide variety of measures, so we couldn't do a meta-analysis. So conducting the systematic review was important for us in trying to understand whether we needed to develop something new or adapt something that was existing, and we certainly found that we needed to develop something new. So we then entered into a formative phase, which was then speaking to and I've reflected on some of these findings already, but to children, parents, teachers, and school counselors about what the interventions should look like and who should be involved. We spoke to 22 young people, 21 of their parents, 17 teachers, and 6 school counselors, who told us that there was certainly an urgent need for interventions like this, that mental health issues were seldom addressed at home, that whatever we developed, that it had to be engaging, energetic, and interactive, and that the sessions should focus on building self-esteem and resilience. So it was already at that point that there was mention that perhaps the outcome shouldn't focus necessarily on reducing anxiety and depression, but those are nonetheless important secondary outcomes, but perhaps primarily should focus on the skills building, which we certainly found later on to be quite important. They suggested smaller groups, and this was interesting at the time that we had this finding, because these findings were still pre-COVID. As a result of COVID, we had to adjust the study, and that was when the children were still attending school on alternate days, and they then had smaller groups as a result of these alternate days. So actually for the intervention delivery, that worked out well, that there were smaller groups as a result of that. Delivering to whole classes is something that we actually haven't piloted yet, delivering to full classes. So the class sizes in the schools that we worked in was about 40 learners in a class. And at the time when we were delivering the intervention, which was 2021, there were still about 15 to 20 learners per class, which worked really well. So that's some of the challenges that we still have going forward, is understanding more about what it would mean to deliver to whole classes. So that's going to be interesting when we go forward in terms of trial. They were concerned about scheduling and timing, so when we could deliver. And we actually found that the scheduling worked really well, but I'll talk about the difference between the two schools in terms of the delivery. And as I said, that our participants told us that they would prefer for it to be external facilitators, so not teachers or not school staff delivering the intervention, which was different then to the systematic review findings. So we then went on to develop the 4 Steps to My Future manual, which was based on the formative work, as well as input from various stakeholders. And we ultimately came up with these 4 steps, which you can see, which for those of you who are familiar with CBT can identify some of the components there. But our first step was valuing who I am. So we were specifically looking at enhancing self-esteem. In step 2, think that you can. So we were interested there in promoting helpful thinking, so helping children to identify both helpful and unhelpful thoughts, and to promote more helpful thinking. Help myself to feel better, so with a focus there on developing emotion regulation and using strategies that they can do to help themselves feel better. And then in the last step, focusing on making it happen. So focusing on goal-focused action and problem solving. So that's just a quick overview of the timeline, and to show that during COVID we had to find, we weren't able to deliver, but we nonetheless had to find out how this might change how we deliver the pilot the study. So nonetheless, there was now more than ever, which was a catchphrase for COVID, now more than ever, had to focus on social and emotional catch-up. Children were highly pressured to complete the academic year. They had very little time to just be children. And so there was lots of pressures. And as we know from other studies as well, that mental health became sort of a real issue amongst young people and amongst adults too, but that there was nonetheless an importance now to be able to focus on ways in which we could improve well-being. So we adapted our protocol, and we really had these two objectives. Our primary objective was to determine the acceptability and the feasibility of the 4 steps to my future program. So our primary objectives were around acceptability and feasibility, and secondary to that, we then explored pre and post intervention changes on a number of psychological measures, which I will mention. So it was a 2-arm randomized feasibility pilot trial comparing this intermediate intervention group to a delayed intervention group. So similar to how this to the studies that we reported on in the systematic review. So we used this waitlist control approach. We randomly selected 2 schools in the Western Cape within which community keepers operate, so the NGO with whom we partnered. This was important, partnering with the NGO, as I mentioned, for ethical reasons, but also when we think about the long-term sustainability and scalability of the work. Ultimately, the interventionists who were involved in our study were psychology students with a master's degree and also registered counselors. And so we would need to think about ultimately who would deliver this program, if not the teachers themselves. And perhaps future work could explore that, but our formative work found that teachers were not interested in being the ones to deliver this intervention, and also agreed that these should be external. So then if external, who would ultimately to deliver this? We tested this with psychology students with at least a master's degree. So it was important for us to pair with an NGO for that reason. Both of the schools that we piloted this work at are part of the South Africa's National School Nutrition Program. So it shows us that these are children from difficult backgrounds. And we focused on the grade 5 group in particular. We did want to focus on grade 5 to 7, although at the time of delivery, the schools had told us that the grade 7s were focusing on completing their sort of final year of primary school, so it was not a good time. And as a result of COVID and the classes being split, it was actually going to not be feasible with the resources that we had to be able to double up on all of the intervention support that we were offering. So because the groups were split, it was as if we would be delivering to 5s and 6s already just with the 5s, because the groups were split. So we simply just didn't have the resources then to deliver to grade 6s as well. So this gives an overview of when we did baseline, which was in April of that year. We then delivered to the first school first, and the delivery at the 2 schools was different because of when we were based at the school. So for the first school, we were there during the second term of the academic year. And so we were able then to deliver as planned. So 8 lessons over 8 weeks, 1 lesson per day. And we experienced a number of gaps in delivery due to COVID and the closures at the time. But for the delayed intervention group, we delivered the intervention during term 3 of the academic year. And this is very close to term 4, where no research is allowed at schools during term 4, but also the end of term 3, there's also a lot of exam preparation going on. So for the second school, they told us that you can deliver the intervention here, but you've really only got 2 weeks to do this. So from our point of view, it was interesting then to see how we could go about delivering the intervention in 2 weeks versus 8 weeks, because I think ultimately being able to deliver it in a shorter amount of time also might be more attractive to schools than being based there over 8 weeks. And ultimately we saw sort of no real difference in the outcomes whether delivered over the 8-week period or the 2-week period. So it certainly gives us an indication that the intervention is flexible in that way. So just in terms of the description, so we had these 8 lessons, which were timed to be between 20 and 25 minutes. And the reason for that was because that's the length of the classes. So unlike in the systematic review, where it was about an average of 10 sessions delivered over 1 hour, we had to shorten these sessions considerably to fit in with the time period at schools. Delivered over 4 to 8 weeks, but we found that could be delivered over 2 weeks as well. And we split the program into 4 steps. So this gives a brief overview of what these steps look like. So step 1, so you'll remember, which was ultimately focused on enhancing self-esteem. We would then start with a brief introduction about what the program was about. We would then have some activities related to self-esteem and respect. An important activity here was to identify your own strengths. So we had a couple of tasks related to that. And then we also gave them a home task, so to be able to reinforce some of the content at home. And we were mindful of how we named that, so we didn't want it to sound too much like homework. The second lesson then started with a recap of the previous session, and then we focused on accepting ourselves and being kind to one another, all of which related to enhancing self-esteem. So then step 2, around valuing who I am, we had some tasks around that. And so you can have a look at some of the others. This information is all captured in our protocol paper, so we've detailed all of the information there. So the structure and the format was then sort of, in terms of the training, we held 2 trainings with our interventionists, and also invited community keeper staff to come to the trainings to give their input, given their familiarity with the school context. So that was key. So they could tell us, based on our prototype that we had during the trainings, which activities they thought would work well and which activities they thought might pose a problem. So we had one very practical activity that involved balloons and paper clips and strings, and the idea of doing away with that activity really just had to do with classroom management, and especially at that time we were thinking about delivering to 40 learners at a time. So that just goes into some of the characteristics of the supervision as well. So for anyone interested, there's more information about that in the paper. So then just looking at the specific feasibility objectives that we were interested in. So our primary objectives was not to look at anxiety and depression. That was included as our secondary outcomes, along with looking at emotion regulation, self-esteem. We also had a bullying measure. I'll go into the measures in a moment. But fundamentally, we were interested in looking at rates of parental opt-out. This was an important strategy that we had adopted from some of the other studies that had been conducting universal school-based work, that there was, of course, initial concern that if we were to send out the informed consent forms to all parents and have all parents bring those consent forms back before their children could take part, that might lead to some delays, or that might then also lead to some children not being able to take part simply because parents didn't return consent forms. So what we did instead was then follow an opt-out parental consent, where all learners would take consent form home, but only those parents who did not want their children to take part would then send the forms back, and that's how we went about it, and similar to other studies that that have used this approach within schools. So, of course, a question that might come up is, well, how do we know that the parents themselves had actually received and read the consent forms? So in our work in particular, we followed up by phoning and seeing whether parents were able to get the forms, but delivering this to more schools, and that might not necessarily be practical or feasible. So and consistent with other work is to rely on the fact that parents who may then have a concern return the consent form. So this is a viable strategy and worked well, but it may not necessarily always be possible to follow up individually with all parents. And many parents we weren't able to get hold of either. So that also posed a challenge. So we would then also had to look at the rates of child assent. So how many children declined to take part in the program. So even if a parent said yes, children could obviously also say that they weren't interested in taking part. Those children were not necessarily removed from the classroom, so they were given an option. They could leave the classrooms during the times in which the program was delivered, or they could stay in the class and do something else. And so there were very few children. I'll give the numbers in a minute. But most children stayed within the classroom and either just sort of slept with their hands, with their heads folded, put their heads on their arms, or were just busy with homework or with other activities, so that they didn't have to leave the classroom. We looked at rates of assessment completion, so how many participating children completed the assessments at baseline, post-intervention, and 1 month follow-up, and we definitely did see some decline over our various time points. We looked at program completion, so how many actually received all of the 8 sessions, how many attended each of the sessions, and then whether the program sessions were delivered fully as intended, as an indication of program fidelity. In terms of acceptability, we did exit focus groups. So after intervention delivery at the schools, we did semi-structured interviews with learners in particular to understand what they enjoyed about the program, what they did not enjoy, what they would recommend we do in the future. We also had fidelity checklists completed by the observers. So in addition to the interventionists who were in the classroom, so there were 2, there was also a 3rd research assistant who would then have a look at the extent to which children were interested and engaged in the various activities that were delivered. And we also had teacher feedback, although important to say here that teacher presence within the classroom was optional. So in our formative work, school counselors in particular said that it might be important for teachers to be present in the classrooms for the sake of discipline, and this was actually quite an important factor in the end. But we made teacher presence in the classroom optional because of what learners had mentioned about perhaps not feeling comfortable enough to share or engage if they knew their teachers were going to be in the classrooms as well. But we certainly found that teachers themselves who were part of the sessions enjoyed it and could then also, and that learners themselves also were also still participating and weren't too hampered by teacher presence in the classroom. So those teachers who were there, they were then able to deliver some feedback about their impression of the facilitators and also their impression of the extent to which they thought the young people were engaging and enjoyed the various activities. So we looked at a number of socio-demographic variables. We had a number of measures. So we looked at anxiety and depression using the revised child anxiety and depression scale. We looked at self-esteem. We looked at goal setting. We had a happiness and well-being measure, which was adapted from the PACES trial, which is a UK-based universal intervention. We looked at emotion regulation using the ERQ, the Emotion Regulation Questionnaire, the child and adolescent version, and we looked at bullying as well as the revised child impact of events scale. We received consent and assent. Our data collection was facilitated by trained research assistants. and measures were completed at the various time points. And there was also a second research assistant on standby to help those learners who had difficulty completing some of the study measures. So delivery at school 1, as I mentioned, was able to take place as 8 lessons over 8 weeks with 1 lesson a day. And delivery at school 2 looked a little bit different with 8 lessons over 2 weeks with 2 lessons per day, twice a week. So that was quite intense for the interventionists, as you can imagine. The learners at schools were mostly the same age on average. They were mostly male and Afrikaans speaking. More learners at the delayed intervention group had ever repeated a grade, and learners mostly lived with both biological parents. So that's just a brief summary of some of the characteristics. If we look at the outcomes, we can see there that rates of parental opt-out was quite low, so just 2 at school 1 and none at school 2. Most children agreed to take part, and so those who didn't were then invited to stay in, or if they wanted to go somewhere else, that we had supervision arranged for them. That most were able to complete the measures at each of the time points, although by time point 3 or so, we could see that only 64% of the learners completed measures, and that was related to term 3 and to the intervention delivery being so close to exam time. So that's an indication for us about ideally when something like this should be delivered, which is earlier on in the academic year. In terms of learner attendance, most were able to attend all of the sessions, and program fidelity was then rated as quite high. So for fidelity checks in particular, we used the study-specific measures where facilitators and learners seemed to be highly engaged, and there was lower teacher attendance in the sessions for the delayed intervention group, and so perhaps that may also have contributed to perhaps lower learner attendance near the end of the session delivery at that particular school. In terms of acceptability, we were able to look at to gather this information from those focus groups with the learners, and they found that the facilitators were really good. They enjoyed the various aspects. They said again that they thought it would be better if the teachers were not present in the class. So for those teachers who were, they were mostly able to recall the content, which was good for us. They enjoyed our breathing activity in particular. So during these focus groups, many of the learners were doing the 4-5-6 breathing, and then also our catch it, check it, change it. We had sort of developed these hand gestures, which helps them to catch a thought, check it out, and then change it if they need to. So children enjoy the more practical sessions related to the program. And then for our secondary outcomes, we found significant before and after for both schools on emotion regulation in particular, and then on self-esteem, and not so much on anxiety and depression outcomes. So this helps us to think about how we should pitch the intervention in the future as perhaps focusing more on enhancing resilience skills rather than focusing on anxiety and depression, but nonetheless measuring this as an important secondary outcome. So the findings tell us that the study is certainly feasible, but it's not yet a fully powered trial, and this is where we're heading to. So we were able to publish the findings in 2022, and we're hoping to find the funding necessary to deliver the randomized control trial. So that's been our biggest hurdle is finding an appropriate funding mechanism for this work to go forward. And there's certainly a lot of opportunities, but we've still had some challenges exploring that. That the program is certainly flexible and adjustable. We were able to deliver it during COVID, and we were able to make changes as a result. But perhaps in the trial work to come, we'll really understand more about what it's like to deliver to whole classes within a South African context. So we can certainly adjust the program to fit with school schedule. we see that the facilitators were postgraduate psychology students with relatively little training and had little deviation in their delivery. So so it nonetheless tells us about who could deliver the intervention in the future, and certainly through organizations based within the school, so through community keeper staff or through similar NGOs. And that it was important for school buy-in for us to be able to collaborate with an organization like Community Keepers. So it's important for those of you who might be considering school-based work that this collaboration is quite important. So we were also very much then interested in understanding what some of the intended or unintended consequences were of conducting this research within schools. And so we used a particular methodology to understand this better, which is known as ripple effects mapping, which is an appreciative inquiry. And I'd be quite interested to know if anybody is aware of ripple effects mapping, who's attending today, and if you've used this in your own work and how it's worked for you. But for us, it was certainly quite a novel approach, and certainly novel to do this among children and young people in particular, as the studies that we found is mostly on older adult populations. And so what ripple effects mapping allows us to do is to really capture the wider unintended consequences. So by the time we had done these interviews, which was last year, quite a bit of time had elapsed since program delivery and in speaking to the learners. So as I mentioned, we focused on grade 5 learners at the time of intervention delivery. So 2 years later, they were in grade 7. So we really had to speak to them last year before we then lose them to going off into high school or wherever they may go, and to be able to understand from them, as well as the other key stakeholders who took part in the study, their parents, teachers, and school counselors, about what being not only involved in Forceps to My Future, but certainly in terms of the interventionists, the research assistants, the counselors, the teachers, what were some of the other ripple effects of being involved in research like this, and not just in the intervention. And so we had this work which was led by a clinical student training with us, and participants were then all of the various stakeholders, and data collection mostly took place in person, so at the schools, and we had I think 2 groups that were facilitated online. And these ripple effects workshops, I'll talk a bit more about that, but was facilitated by 4 research assistants who were not involved in Forceps to My Future. And the data from these REM workshops, which are guided in a very structured way to be able to work with your participants to essentially, on a large sheet of paper, with the use of a timeline, so from the point at which the research started through to the intervention delivery to the present day, what were some of the key effects of being involved in research and in the intervention that they could identify that was both positive and negative for them. And so the idea is then to code these maps, and not necessarily to engage in a thematic analysis, but rather to look at common significant pathways across each of the map to see whether there is any overlap. So you look at these chains of interconnected activities, which you then color code through various boxes and arrows. And so we were able to then do 5 ripple effects workshops with 26 participants, so across our various groups, and we were able to produce 8 maps from these 5 workshops because the learner groups were split into smaller groups. So we had a number of learners take part, and so within on that particular day, we had them split into smaller groups, and we could identify 5 themes that captured the research impact. So in the first instance was the direct and the expected mental health benefits to the learners, and the findings showed that involvement in Forceps to My Future had direct and expected mental health benefits. So in particular, the practical skills that we were able to deliver was impactful, and learners were still able to remember many of the skills at that point. And they were able to self-report that they felt the program improved their academic performance performance, that they were able to make better decisions, and that they still benefited from the self-esteem activities that were shared. So that was quite positive. So these were many of the expected benefits at the time of delivering the program. So we were happy to see this this particular benefit sustained. The next was in terms of interstakeholder relationships, and our findings show that the interstakeholder relationships that were forged through the program had many benefits. Sorry for being distracted here. Oh, I'm sorry. Fatima said her internet had cut. I hope everybody else is still there. I can't see anybody else, but I'm also aware that we're running out of time. So we had a number of important interstakeholder relationships, but an unintended outcome, though, was that one of our participants, one of the counselors, said that they did not really feel as in partnership with the researchers as they would have liked. So that for us was really something to ponder and think about how we could better strengthen our relationship with our partners to make them feel more included in this partnership, which is certainly very important in terms of co-development, co-design, and collaboration, and that if our NGO collaborator perhaps shared this lack of partnership feeling, that perhaps our schools may have felt this way as well, but perhaps didn't voice it in that way. And so it really makes us think really carefully about what it means to form a partnership and how we can make that meaningful for everybody involved. Then our research assistants in particular reported a lot of professional skill development and growth. So many of them have gone on to further their studies and to focus on aspects that had been identified related to this work in particular. And we also found that delivery context matters, and that we need to think about the broader school context, the school environment, what's happening at the school when we deliver programs like this as well, and how that might impact on the learners. So those were, and then there was also a number of recommendations for future implementation. And sorry for rushing through this a little bit. I'm just aware of time and I just want to get to some of the other observations. So this is just quickly sort of what a ripple effects map would look like and how you would then go about digitizing that map and then using color coding to identify key significant paths. So for any of you who might be interested in exploring, just sometime after an intervention has been delivered, a methodology for mapping some of those unintended consequences. So the work definitely shows us that early intervention efforts are needed, and that schools and school-based intervention efforts are certainly worth pursuing. And so our study, and we are aware of a number of other school-based work that's going on, which is really promising, and that we need to do more randomized controlled trials. In fact, fewer than 10% of clinical trials of psychotherapies are done in low and middle income countries. So we really need to find ways to test this through randomized controlled trials. But we certainly found that there are challenges, and a big challenge actually in the current literature, and that's currently being debated, is actually building the case for universal school-based mental health interventions, largely because targeted interventions do show much larger effect sizes on primary outcomes, and when those primary outcomes, as I mentioned, are related to mental health outcomes such as anxiety and depression, that we do see far smaller effect sizes or even non-significant pre-posts on those measures for universal school-based. So then it becomes a question about where are resources best allocated, and perhaps if targeted interventions do show more effect, that resources be more allocated to that. But I also mentioned that we need to be able to deliver interventions at all levels, and that we're not saying that universal is the only intervention to be offered, but is part of a suite of interventions or ways to intervene to address that treatment gap. Increasingly in the school-based universal literature, some of the challenges is that there seems to be a lot of unintended harm associated with delivery. So I'm not sure how many of you are familiar with the Myriad trial, which was conducted in the UK, as well as more recently the DBT universal intervention that was delivered, but nonetheless showed that compared to baseline, students were actually reporting more problems after receiving the intervention than when it had first than when they had first been assessed. So it makes us and Dr. Lucy Folks, who's part of the University of Oxford, the experimental psychology lab, has made it part of her program of work to look at some of the harms associated with delivering universal school-based interventions, and some of these unintended consequences that are emerging. So increasingly, when these studies are being designed, researchers are being encouraged to think about what might be some of the harms associated with this work, and then relate to that how that would be mitigated or addressed from an ethical point of view. Then funding for RCTs continues to be a challenge. So finding ways to then test this with long-term scale-up in mind as well, and so finding ways to support that it still remains quite a bit of a challenge. Then there's challenges related to working within schools. So finding so in terms of when the sessions are delivered. So I spoke about, which terms academically were going to be more important. But then also we know that with many interventions that are delivered in schools that may not necessarily be focused on mental health, that they nonetheless use a particular lesson time. And so we need to think about how do we then juggle all of the various programs and interventions that are delivered in schools within the curriculum, but also not overwhelming the school curriculum. And then thinking about parental involvement and the benefits and barriers of this. And we certainly see that it is going to be beneficial to more meaningfully include parents, but we need to understand more about how exactly to do this. We are very aware of the barriers parents face, but nonetheless also that they keenly want to be aware. So trying to find out how we can meaningfully include them is an important avenue of future research. So opportunities. So those are some of these challenges I have spoken about. So opportunities is that we know that conducting this work is helpful for early identification of mental health problems. So if we are delivering universally and we are assessing children on a number of psychological outcome variables, that we are able to identify then early on who might then need to be able to who needs to be able to receive more targeted intervention and to be able to then connect them to that care. So that's important. It does help to deliver mental health information to learners in a potentially stigma-free way, potentially. So it addresses a lot of the stigma barriers, and providing children with these resilience skills early on is also very important for emotion regulation, which is a key executive function. And improved executive function is also protective of, for example, conduct disorders later on. So there's a lot of importance around that. Opportunities for establishing partnerships. So I spoke about sort of the importance of how you are building the partnerships and then sustaining those partnerships for the long run, which is important for scalability and in terms of who will ultimately be delivering this should the intervention be scaled up. So our ripple effects work was really important there in identifying opportunities for more relationship building with key stakeholders, and then the opportunities of capacity development that went along with the various research assistants who were involved. And I'm aware that I'm out of time. So lastly, just methodologically, that we need to be able to explore more about how to flexibly adapt to the school environment, especially when delivering this at full capacity, more consensus on the outcome measures for future meta-analyses, and then just thinking through some perhaps digital interventions and seeing what that might look like in the school context as well. But that's the end then.
I really enjoyed your presentation. Your methodology is just off the roof, and I really enjoyed listening to the way you not only conceptualized but put everything together. So, yeah, really amazing work, and yeah, it would be so amazing if we could get more funding to have registered counselors and social workers and those types of skilled professionals within schools to really do the type of work that you have been doing. So, yeah, really amazing work. Thank you so much. We have a few questions and comments in the chat box. The first one is thank you for the presentation. Regarding the instruments that you used for data collection, have you validated those instruments, and do you have any references that you could direct towards the attendees? If you can share, if you do have these things, you can send it to me and I can distribute it to all participants in the webinar today.
Yeah, so thank you. So the arcades in particular has not been validated. So so we don't have within the South African context. So we have sort of what we could find in terms of psychometric properties, and those were quite good, but not necessarily not much beyond that. And then for the other measures, so I mean the self-esteem that the Rosenberg self-esteem that certainly has, and some of the other ones. I don't think the ERQ has in particular. And then some of the others were study-specific measures, so there wasn't validation around that. So, but this is an important question about the measures that we're using, and that a lot more work needs to go into that. But I'll share with you what we have.
That sounds good. And then we have another comment. Thank you for the presentation, Prof. Glad I got to attend and meet you virtually. Not sure if you remember me. The person's name is Akona. The question is excuse me if I missed it within the presentation. Were existing class times or planned school class programs cut short to accommodate the interventions program?
So yeah, we had taken the life orientation lessons within the schools to deliver the program. So yeah, so class time from the life orientation lessons, which was what the schools mentioned we could use as a time to test, was taken. Yeah.
Okay. And then exit interviews. When were these conducted with learners? Before class began, break time, or after school?
Yeah, it couldn't happen after school, as children had a lot of extramural activities that they needed to attend to. So it happened mostly during break time. Yeah.
Okay. How, if at all, involved were the teachers in the scheduling process?
Teachers were quite important in the scheduling process. So they would inform us about when the life orientation lessons were, and then we make sure to be at schools at those times in order to deliver the interventions then. And they were also key for communication with the interventionists in terms of timing, and if there was an event at the school on a particular day. So if there was a school death and it just wasn't, one of the learners passed away, it just wasn't a good day to come. So then to arrange that, we would then go on a different day. So teachers were very key to the scheduling and to the ultimate delivery in the end.
Okay, and last question. How much relationship building was done pre-intervention implementation at the schools?
So we had met with the schools often and regularly in the beginning, with the principals, with the teachers. We had, and also because the formative work was largely with the school staff as well, to be able to understand from them whether there's even interest in a program like this, and whether ultimately, if something is developed, whether they would be interested in being tested at the schools. And as I mentioned, there was no doubt. a real need identified. And so we spent a lot of time at the beginning, even with our with the school counselors, just understanding from their perspective what their needs were and how we could address those needs. So we spent a lot of time initially building those relationships, understanding from the schools themselves what would work best in terms of learner involvement, understanding from them at that time how would it fit within what's currently being done at the schools. So there's a lot of time initially that goes into building that rapport with the schools, and to be able to get to the point where you can be in the schools as often as you need to be to deliver something like this. So there was a significant amount of time spent on relationship building.
There's another question regarding parental consent. If you were unable to contact a parent, would you still include the child in the intervention?
Yes, we did, because we still sort of covered by the parental opt-out procedure, which is that if parents returned the slip not wanting their child to take part, that then meant that child was excluded from the program.
Yeah. So, side question from me. I think that the work that you're doing is really amazing. And one of the concerns I had related to one of the things that you were measuring, which relates to to bullying within schools. And we know that within many of the schools, there's high rates of violence and aggression. And so I really like that you were focusing on the emotional regulation and those types of primary outcomes in addition to the depression and anxiety. So I was just wondering, could you maybe advise how a program like this could maybe crack the students' ability to maybe address the bullying aspect within schools or violence within schools? Do you have any information that you were measuring that would relate to that?
Yeah, so we didn't see any drastic changes in. So we used the always bullying
Mm.
scale, and we used two items on that scale. So I have been bullied or I have bullied. And we didn't see any major before and after changes, but also not really high rates of self-reported bullying, but more have been bullied. So while we didn't focus particularly on addressing bullying, we know that uh, bullying is probably one of the most important um, uh, uh, issues and if you think about that social determinants model that I showed earlier, sort of that school climate, um, and those proximal and distal factors, that bullying certainly contributes to a lot of the mental health challenges that young people are facing. So that's quite important. And I think that there are some programs specifically that focus on violence prevention and bullying in schools. So there's good work being done on that.
Any last comment you would like to make, Raf?
Please, can more people get involved in this work? That would be great.
So from the DRM to the presenter, you're amazing as usual. Thank you so much. And to all our attendees, thank you for being here. And that's a wrap from us. Have a great day further, everyone.
Thanks, you too, and thanks everyone for being here. Have a lovely afternoon. Goodbye.